big wins on the journey without going too far? How do we do that? Any thoughts on that?
That's an amazing question. And
Jay
I
is like the
think
amazing questioner of all
I know,
questioners here.
I love it. So I think so much of that we as individuals have to know what our boundaries are and be able to communicate them and share them and understand that other people aren't going to know those boundaries. And um, if we're someone that doesn't want someone else to comment on our bodies, I think it's helpful. We have to let people know that we can't expect others to know our expectations. And I think sharing our wins is so important. We have to celebrate, um, but not in a way that we fear or have very strong negative feelings about our previous body or people that still don't live in a body that looks like ours. I mean, some of my regrets that I think that I've had throughout my lifetime, it always comes back to me. I remember there was a time when I was in a weight reduced state, in my early 20s with a group of friends. And I made a comment. I had lost some weight of how great I felt. And I was in a size, I think 12 at the time. And I would never go back to a size 18 again. I'll do anything 18, 20. I'll never get back there because I don't want to be in that kind of body. And then immediately I was just trying to share my experience and my upset with my previous body. And then I could see the look on the faces of some of my friends that were still living in that body. And it broke my heart. And I hate to say at the time I didn't have the emotional maturity to be like, oh my God, I'm so sorry. I just kind of shut
Mhm.
down. So I think we have to celebrate them in respectful ways and not in a way that becomes unhealthy. Like I deal with all kinds of patients across the age spectrum. Like I take care of children down to the age of 5 with weight concerns. And we have these conversations often with their parents because this is what I see. And this is a challenge with WINS of they come in and they've lost weight and the parents will like cheer and celebrate because they're the scale's gone down and I'm like, oh, but what happens when it doesn't go down? Like
Mhm.
if we make that the only thing we're concentrating on, and if we give that praise and we over celebrate that, I mean, the scale doesn't go to 0. That's not the goal, right?
Mhm.
So if we create this mindset of needing that dopamine hit for that scale to keep going down to continue our healthy patterns, we're just setting up another pattern of disordered but
Yeah.
unhealthy behavior.
And it's also having been there, having lost a bunch and then regained. There's also that
Hmm.
moment of all of those people who are, um, totally excited for you the first time around, right? And then you realize when you reverse how much disappointment you've created, even though they're not saying it, because of the comments that were so positive that you weren't getting before, right? It's a lot.
Hmm.
It's a lot.
Yeah. And that is the kind of the concern because, like, I have a lot of people that ask me, can we post before and after pictures at your office? Or will you post our before and after pictures on social media? And I'm not a big fan of before and after pictures, because I don't like the after,
Yep.
the idea of the after, that this is done, that I'm cured, that my journey is over, and I'm in the after. I'm all for it. If you want to post a picture of you living your best life today and we celebrate that, awesome. Let's do that. But I don't want to encourage an unrealistic idea that this journey's done and that I will automatically get to always be in the body that I'm in now and I'm in the after.
Yep.
Because at any point in time, something could happen to me and I might be back in dysregulation because it's a chronic disease. So, and I always want patients to kind of understand that. And do we want to hear that? No,
No,
right? But it's the reality, and setting us up for those realistic expectations helps us not blame ourselves if that time comes. Because I don't want patients to be scared to come back in and see me because they feel like I'm going to be disappointed in them because they had a weight recurrence. I want me to be the first person that they run to, and for me to be like, Yeah, this happens. Let's figure it out. I'm not blaming you. This is your body. Let's
I've
figure it out together."
in my entire life, I've not encountered a doctor that hasn't been disappointed when the scale goes up. So that's very, very kind of you for your patients. Uh, Jay, as you know, you've met before. Jay's our GLP-1 community Buddha. Folks, if you're not following Jay or Dr. Golden, please give them both a follow. Jay, do you have a wise question as usual?
I don't have a wise question, but I do have a question. I When I heard that you were coming in today, I was like, yes, more golden gems. That's why I've dubbed your wisdom golden gems. By the way,
Oh.
um, the language that you use, I would like to say it's very thoughtful and very inclusive and very acknowledging of the fact that obesity is a spectrum, right? Where there's ups, there's downs, there's a way forward, there's a way backwards. That it's just a spectrum
Mhm.
for obesity. How can we, as people that live with obesity, help use that language and carry it forward? And how do we help other people use similar language? Not the exact same language, but how do we like carry forward with the language?
Jay, can I have you come with me everywhere? They're amazing, these questions. Uh, that, I think that has been a combination of lived experience. I've always been a very perceptive person, and I pay attention to people's body language and how they react based on the words that I assume the words that I use. I've learned to be very comfortable in asking my patients, "I'm sorry, I noticed a change in your body language. Did the language I use not sit well with you? Are
Mhm.
you comfortable enough to share with me? Because I would like to learn to speak differently." A lot of my patients, when they first come in, I'll ask them, you know, I tell them, when you're in this room, if I ever use the word obesity, it's that I'm talking about the disease. I know we don't like that word. And I always joke, they don't listen to me when I say we need to change it, but and I ask them, what words do you use? What words work for you? What words do you want me not to use? And in my practice, I train my team. We don't use the word exercise. We use movement. We use
Yes.
maybe physical activity, but it's all, how do you move your body? Exercise is a four-letter word in our office. And so is diet. We intentional eating. What is your nutritional goal? We don't talk about diets, and and we really try to get everybody away from, because everybody wants to ask me what should they weigh, and I always like to pivot to, what do you think what do you think that day in your life will look like when you're at that weight? That's what I want to know. What is your health vision? What do you see yourself doing? Because if you could live that life, like if I told you, say somebody wants to be ever less than 200. Okay, so if you stepped on the scale right now and you're 199, what do you think that changes for your life? Like if you were still living life as you are, but the scale said that, would you be happy? And they're like, no, because I can't crawl around with my grandkids and I can't do this. And well, why not make that our goal? Because it's what we make the number mean, the life we think we get to live at that number. So why don't we just make that our goal instead of assuming I get to live that life just because that number is that way? So I think there's just so much shifting, and it's just a lived experience. And wanting to know people, wanting to relate to people. And yeah, like we talk about weight health rather than when I work with children, I talk to the parents about we don't talk about weight, we talk about healthy growth, stabilizing with our vertical growth. We talk about healthy bodies, we talk about strong bodies. When I talk to adolescent girls, we talk about let's find our authentic body for us. Um, we don't, we try to, I'm very intentional about the language that I use. And I think it comes from sharing that with people. I don't hesitate. And I tell patients, my patients will say, I've always been obese. And I'll say, and I always I ask permission. Can I comment on that? The word you used, obese. Do you mind if I share my thoughts on that? And they usually are like, sure. Right. you know and I'll tell them, so this is my understanding, like you're not an obese person, just like I have melanoma. I'm not a cancerous person. I'm a person that happens to have cancer. I am a person that happens to have something. My adipose tissue expands more than is healthful for my body. That has nothing to do with who I am. And I try to tell them that. So I will ask you that as you come in over time. I know it takes time, but you are a person that happens to have the disease of obesity. You're not an obese person, and language matters. And so being willing to talk to people and just not in an argumentative way, but in a like, hey, I noticed you use this language. Can can I share with you how that sits with me? Because it would you like to know how it makes me feel? And most people are kind of like, sure. Because a lot of people are just taken aback because they're not used to someone being comfortable sharing how language affects them. And that's the only way people are going to learn.
So we're going to mix a functional question in, and then I'm going to take a moment because it's, I don't know, it's someone I know who's studying for the obesity med boards. And so he's asking, do you document under Edmonton score as opposed to BMI? I have no idea what that means. Um, and he just
Right.
texted me to say ignore the question, but we already asked it, so it's too late.
Yeah. So what he's talking, and actually this is a great conversation. And y'all stop me because I can go on and on and on about this. But um I think what he's asking is how do we evaluate, diagnose, determine the severity of someone's obesity disease? So BMI is really just a screen. Y'all know it's that height, weight number that supposedly could predict how much body fat we have. I mean, y'all, the Rock does not have obesity, his BMI, I mean,
Mhm.
when we look at people that have a lot of muscle mass, it makes the BMI does not work. And when we see people that may happen to be in smaller bodies, they may be misclassified as healthy, but they may have more adipose tissue than is helpful for their overall body size. So BMI is just a screen. It has to be confirmed. So obesity should never be diagnosed by just BMI. You should always confirm it with other measurements, whether it be whatever's at your waist circumference, height to waist ratio, bioelectrical impedance that can actually tell what the body compartments are made up of, or like DEXA scan, right? Because obesity is a disease of having more the quantity of adipose tissue, the distribution of adipose tissue, and the health of adipose tissue, and having more than is healthy for our body. And unless you can tell that, you don't know. And they feel like if you have a BMI over 40, you may be able to assume. And we'll see that they have to study that, and that may be accurate. Um, but then that just still only tells us how much body fat you have. It doesn't tell us how that impacts your health. And it may not. Someone may have a high amount of adipose tissue, but at that moment in time, it may not be causing dysfunction in their life. They may be thriving. And so in that individual, the EOSS that he's talking about is the Edmonton Obesity Staging Score. And that's where we look at how severe is this condition for this person. So if their adiposity, so the amount of adipose tissue has expanded to the point on their body that they're in a wheelchair and they're in pain, or they're severely depressed that they won't leave their house, that's like stage 4, because their obesity is so severe that it is completely interfering with their life, right? Whereas if someone might have a high amount of adipose tissue, but all of their metabolic markers are fine, they're running 5Ks, they have a great mental health profile, everything, that they have no concerns whatsoever, you may say that that person is stage 0 or 1. And so it's not just about the size of body, it's not just about the weight, it's about how much adipose tissue they have, and then how much it's interfering with their health. So in my chart, I diagnose it based on clinical obesity. I confirm it. I put the BMI in there because the insurance company requires it. But then, yes, I put the EOSS, I put the stage. But what I do, what usually I leave, because technically the diagnosis of obesity, the highest weight, our highest adipose, um, our highest adipose accumulation is where the disease state should lie. That's where our biology is. So that shouldn't change. And then over time, you adjust somebody's BMI in the chart, is usually what happens. Because I've had patients, they may end up in a smaller body and they're like, Dr. Golden, my BMI is 24. I want obesity out of my chart. Remove it all. And I'm like, I hear you. But then that but it's a chronic disease.
That
Just
would
like
hurt the meds, right?
you're not cured. It's well managed. Just like someone with diabetes, their diabetes may be well controlled with lifestyle. It doesn't mean the diabetes is gone and we never have to worry about it again. We have to know that our biology has a predisposition to return to that level if things get out of control. And sometimes those things are completely out of our control.
Thank you. You made the husband very happy, so I appreciate that. Thank you.
Oh, was it him?
Yeah.
That's
Uh,
amazing.
let's see. How do we get more doctors like you in the world? Like, how does that happen, right? Brian mentioned in the chat, like, I hope you're training the next generation of doctors, but how do we sort of make a world where there's lots of Dr. Goldens?
Oh, I'm honored, first off. Uh, you know, I mean, so much of it first comes from individuals entering the profession with the best of intentions, and wanting to have that connection. And in no way do I imply that's good or bad, I mean, I joked about wanting to be a radiologist earlier, and we there are radiologists that have great bedside manner and good hearts, but there are some people that are radiologists and they know that all they want to do is find that tiny little stroke on the screen and help someone else take care of a patient. And we need those people. But the individuals that choose to go into family medicine, pediatrics, and obesity medicine, psychiatry, making sure we support them and protect their compassion and protect those intentions. I remember in medical school and residency, they would show us studies and they would measure medical students' empathy at the beginning and then at the end of med school. And wow, I didn't the way it dropped, right? Because there is an emotional there's just emotional burnout that happens if we don't take care of our providers. And so helping our providers stay healthy, helping our clinicians stay healthy, and obesity medicine and understanding it at every level has to be taught from early medical school on, in order for us to get past this. Because it's not just there, I've met clinicians that get really into the appetite regulation, but they don't really get the emotional experience. They don't really get the trauma. They don't really get how difficult it is afterwards when your friends are taunting you because you won't do margarita night with them and you don't eat like they used to. They don't get the challenges of the food bonds. They don't get the challenges of, I remember things like my family, we've always been larger individuals as a family, and it was like you look like a golden, it's fine. You look, and then the messaging was very clear. You don't look like us anymore, you know. Goldens eat, Goldens do this, Goldens do that, and that is hard on a person when you're told by your tribe you're not in the tribe, those subtle messages over time. And so we have to help our clinicians understand that across the board, we have to help them identify the challenges and be able to relate to people, or at least realize that that's not their skill set, and get them in with other people.
When it comes to obesity, there's such a large psychosocial component to the disease
Hmm.
that even when the physical part of it gets under control, like patients have to deal with the psychosocial component for the rest of their
Hmm.
lives.
Hmm.
Like, how do you as a clinician help patients navigate that when you're in a society that scoffs at dealing with psychological components of anything?
Right. Oh, I mean, it's so important. I mean, it is hard to t take care of a patient with any chronic disease without understanding how that chronic disease impacts the other parts of their life. And often those are the barriers, you know, to medically stabilizing it. So many what I do in my practice is I make sure patients understand that, you're probably going to be with me for life, me or one of my team members. I tell patients up front, yep, we're going to see you monthly medically. Then we have health coaches and dietitians and movement specialists, and that work with the patients as well. So they can get as much wraparound care as they need or as little. I don't force it on anybody. Like if somebody's like, I will not go see a dietitian, fine, you don't have to, please. Um, but once they're starting to realize that success, and that intrinsic motivation is coming forward and they're doing well, we'll space it out every 2 months, every 3 months, make sure they're doing okay. But I usually tell the patients, I still, every 3 to 6 months, we need to connect, because this is hard. And I expect it to be hard. And it's not if you have a weight recurrence, it's when. I need you to know that, because if you get injured, if you go from having an active job to getting promoted to supervisor, yay, but you're going to be sitting at a desk, and we got to talk through that. I need you to reach out to me because we need to make sure we have a plan for that, right? And and through relationship changes, and you know grief from losing someone, and all the different things of, and all the time they come back and I'm like, hey, it's fine. We No, you did not let yourself go. You reprioritized your life appropriately, and this is normal, and this is how, and guess what, now we get to learn how we get back on track and take care of ourselves. And now we get to build the confidence that, like, oh, I can do this in hard times and easy times. So really trying to set patients up for, like, hey, the cycle, we don't lose weight in a vacuum. Life is going to continue to happen, and we don't maintain weight in a vacuum either. Life is going to be challenging, and you're going to need us. And that's why we're here, and really encouraging them that expect long-term care as a part of your journey, as a part of your skills. It is not a failure to have to keep seeing someone. Just like, I mean, you keep seeing your heart doctor for the rest of your life. I see my dermatologist like twice a year, but just to make sure I'm okay. And we don't question that. And in a disease as complex as obesity, of course, we need to be checking in. And I can't tell you how many times patients come in twice a month, twice a year. And they're like, oh, I'm fine, nothing's going on, and then they're like, well, the kids are going to college. It's going to be an empty nest, and we're preparing for retirement and our budget's changing and all these things that I'm like, yeah, let's talk about that because this is really going to impact our life. So we have to embrace the psychosocial because it is such a part of this disease state. And um it just it in helping patients understand that's not weakness. It just it's a challenge. I love to remind people that you know, all of these cues that come to your frontal cortex, like that's the only part you get to decide what you do with all these cues. But you have no control over all those cues, when, I mean, we all want to hit the red button that says, don't hit the button, you know, but the prefrontal cortex tells us, no, you don't want to hit the red button. They'll call the police. You'll get in trouble. We don't do that. And very much like that, there's so many psychosocial things that go on, that seasons change and oh, we want to have that comfort food and stressors change. And I always tell people that when the challenging things of life come up, when you're at your most challenged, when a spouse dies unexpectedly, oh my goodness, when you lose your job, when something these are severe circumstances that we haven't had to deal with in our loss journey yet. And God, I wish I could protect everybody from that, but I can't. And when it does happen, of course, you go back to the things that worked well for you, right? And of course, you weren't strong enough to like resist those urges because you haven't had to deal with that yet, right? And I just need my patients to understand up front that these are not weaknesses. This is just another part of the journey that we get an opportunity to level up to get past, and then we end up stronger.
Yeah.
Thank you for saying that because I've been saying it. I've said it before to so many people that life is going to continue to happen to
Hmm.
us, even on this class of medications, right?
Yeah.
The life will continue to happen. And people without the disease of obesity, their weight fluctuates because life happens. You know,
Hmm.
like grief happens, life circumstances change, hormone levels change, our levels
Hmm.
of physical ability change as we age.
Absolutely.
Life just happens, and our weight will fluctuate naturally because life happens. And we just because we deal with the disease of obesity and we luckily have a class of medication that's helping us doesn't mean that we're going to be exempt from life happening to us.
Right.
And so we have to be mentally prepared for life still happening. Like
Hmm.
we have a leg up, but life is still going to life at some point.
Uh,
I like to remind people that like the medicine is just kind of leveling the playing field to a point, right? But
Yeah.
individuals who have always lived life in lean bodies, if you will, well, when they go through menopause or their testosterone gets low through life, or if they go through challenges, they gain adiposity too.
Mm-hmm.
So we're not protected from that. The medicines we're on stabilize us to where we can get to a certain point. But then if those things start to add on, the medicine's not like, "Ooh, let me work a whole lot more." That's not how it works. I like with my high blood pressure medicine I used to be on that I'm not on anymore, right? Yes. Uh, you
that we can
know,
celebrate.
I know. Yes, we can celebrate that, right? Um, and you know, I may take it, but then if I drank Monster and stressed myself out and did all this stuff, like my medicine, my blood pressure medicine wasn't going to be like, oh, we got to kick it in and like work a lot harder, right? So we're still going to be challenged with different things in life that will require a different approach at that point in life. And that is okay. That is not failure. That's why I say things like weight recurrence and like, because it is not failure. And that's when people write in charts that patients failed diets, that's something that boils my blood a little because you can't fail something that was never meant to work in the first place, right? Like, I mean, diets are not meant to be long-term things, and we know weight returns anytime we stop an intervention that's been successful. So you can't fail something that was never meant to work for you long term. And we you didn't re people can be non-responders to a certain treatment plan, but like you're not judged for that. Like, could you imagine going around and judging someone for like, oh, you didn't respond to your cancer treatment? Hmm, probably should have tried a little harder, right? I mean, we don't we're like, man, they have a really advanced form of the disease. That's terrible, right? But nobody walks around with like, because unfortunately, 9% of patients don't respond to tirzepatide. 14% of
Yeah.
patients don't respond to semaglutide. It is heartbreaking because society advertises them as miracle drugs,
Mhm.
and for those individuals that simply that's not their type of disease, we haven't found the treatment for them yet. Hopefully we will soon. But like they're left to feel like they've done something wrong because it didn't work for me. And it's they just have a more aggressive form of the disease. And I hope we can figure that out for them as well too.
Yeah, I think one of the things that sort of surprised me on the medication was most of my, weight journeys below, let's call it that or something, have ended when something happens in life, right? And, whether it's 9/11 or getting gallstones, like every time something big happens, I swing back in the other direction. And, I had one of those moments on this med maybe 9 months ago. And what surprised me the most was I had more resilience than I've been used to having in that journey, if that makes sense. Um,
Mhm.
and that was, I think, the biggest eye opening thing for me on Manjaro. It was like, oh, if I work with this, I can get back up that I've never been able to get back up before.
Mhm.
So
It's amazing how the medicine, it's like it creates this space for you to be curious, for you to explore, wonder a little bit more, rather than being devastated by a setback. I feel like, and I try to remind patients too. We have this, I hate to say rule, but this philosophy that I share with patients of like when you go on vacation, please do not get on the scale until twice as long as your vacation was. Twice as
tell
long.
him. He
So if
carries a
you're
scale
on
with him.
vacation for 2 weeks, do not get on that scale for like a month because your body needs time. So lean people, people who have always been lean, you know, when they go on vacation, they gain weight too, you know. Um, but they have learned from experience over a lifetime, their body responds quickly to getting back to their usual routine. And for us, our bodies didn't do that. We went on vacation and gained 10 pounds and we would restrict and diet. And then our body's like, nope, we're holding on to this, maybe a pound. Good luck. But and it's hard for us now having the medicines to trust. And I still do it. Like I'm like, oh my gosh. And my husband reminds me, he's like, what would you tell your patients, Leslie? I'm like, yeah, you're right. Don't get on that scale. Because I mean, the stress on the body from the travel and changing time and the salt from the eating out and uh yeah, it it takes time to balance out, and it's hard to trust that. But if we don't, and I always ask patients, when you get on the scale, before you step on that scale, please ask yourself one question. What am I looking for it to tell me? What do I want? Because if you're getting on that scale the day after vacation and you're hoping, that's not fair. And what is that going to do? Is it going to help you? Probably not, you know?
This is amazing because this is a debate that happens on Friday nights all the time here. Jay is team travel scale. Like he
Team
travels with
travel
the scale.
scale, yes.
Our friend
You
Steve,
bring
who's
you bring the
here
scale with you?
and
I
over
have
in
a very
Japan,
cute travel
travels with your
scale. It's
scale.
so cute. It's so cute. It's so petite
And,
and
and
yeah,
and
it's so
Sabrina walked in just at the right moment, Jay. You'll never live this one down.
Hi, Sabrina.
Oh my goodness.
But I like to collect the data, and so there's just no gaps in the data. So there's
Yeah.
just no gaps.
So,
Yeah.
and it's all about your relationship with the scale and how you respond to it and what are you using it for, right? So if you are someone that if you're still using the scale to tell you if you're good or you're bad, then it's not a healthy decision. If you are using, if you're able to look at it as a detective rather than a judge of like, huh, that's interesting. Okay,
There's no
what do I want to
morality.
do with that information?
There's no
Yeah, as long
morality
as there's no morality
and no
and you can use it
restrictions
as
based around
data,
it.
fine,
No, no
right?
morality, no
Yeah,
restrictions.
yeah. See, I'm not there. I'm not there yet. I still, despite all of the intellectual knowledge I have, if I get on that scale and it tells me that it's going up, oh, the fear sets in and I have to talk myself out of it, right? Because there's this layer for me too of like, because patients comment, people comment, and I live with this fear of like, well, gosh, what are they going to say? Are they going to think I'm a terrible obesity medicine doctor if I have weight recurrence? Like intellectually, I know that I can have weight recurrence just like anybody else. But I live with that. What happens in a year or two if I get pictures or I'm up on a stage and people are like, man, Dr. Golden, hmm, she's not really taking care of herself anymore, and I mean, it's funny how that internalized weight bias and stigma, that fear still haunts us. I know that my body on the outside has nothing to do with my understanding of this disease and my ability to talk to patients and to take care of them. However, I still tell myself, gosh, if you can't take care of your own weight, how can you take care of other people's? And it's sad that we still do that because if I got cancer, I wouldn't be like, well, gosh, I couldn't be a cancer doctor. But we tell ourselves this, and it's just a sign of it runs deep, that fear, and that insecurity and how the world experiences us. It runs deep.
Yeah.
There's a
So
request
there's
come
a
up by
question.
Tay, which I assume that's fake. That's a bad tap, right, Tay? Sorry, go
What
ahead,
happened?
Jay.
So there's a question about in the chat about hyper responders, basically. So there's an I guess an oversampling on social media of people that are deemed basically hyper responders, where people that respond very well to this class of medications, and people are using them as a measuring stick for how they should respond to this class of
Yeah.
medications. How do you respond to patients that say, why am I not responding as well to the medications? Or, how should I expect myself to respond to the medications when they're seeing, the responses to other people? Or
Right.
should people be classifying themselves as hyper responders even?
Yeah. You know, that term, just like so many other words, is all in what we mean by it. Like I think even, we talk about microdosing, and microdosing means different things to different people, right? And so
Mhm.
I imagine when people are talking about hyper responders, maybe they're talking about patients that are experiencing higher weight loss than was reported average in clinical trials, right? But if
Mhm.
you take that clinical trial data and do those waterfall plots where you see how much every individual lost, there were individuals that lost a significant amount in those trials as well too. It's just not reported as the average. Um, and it just goes back to, like, first, I'm sorry. Like, I'm sorry that this medicine isn't giving you the treatment outcome that you're hoping for. I know that has to be devastating. Just like just getting out, like, I'm sorry. I would, just like in any other medical condition, I would be devastated if I was hoping for a significant life-changing response. It's one of the worst things with this, and sometimes one of the things that keeps people from seeking treatment is the fear of, what if I try this too and it doesn't work either? And just the hope of knowing it could be a possibility makes me feel better than trying it and failing it, right?
Mhm.
So apologizing, leveling with them, acknowledging their feelings and their disappointment so they can sit with that and know it's shared. And then talk about our bodies are individual. There isn't an obesity. There are obesities. Like, there are so many different types of obesity. And if the only thing that has caused their personal obesity was that pathway that needed just GLP-1, GIP, yeah, that drug is going to hit that pathway, balance their body's physiology back out, and they are going to be a responder. It is going to be a success for them. Like, that was the right target. But if
Mhm.
they have a different type of obesity, they're not going to experience that. And or some of us have multiple types. They talk about the phenotypes of obesity. I have a couple. I know I have emotional eating, I'm a slow burner, all these different things, and those have to be treated differently. So sometimes it's just patients are getting inadequate treatment because they may need more than one treatment. Just like, some people need three different blood pressure medicines to control their blood pressure. It's not a bad thing. It's just that's their individual body. And so some patients need three different weight regulatory medicines to control each pathway, and then you start to see that response. Um, so encouraging them not to give up hope, encouraging them that we are all individuals, and there's so many things that go into these responses, and also making sure people have realistic expectations, because at the end of the day, we all do have different bodies. If my body is genetically predisposed to, like, carry more muscle mass and carry a little bit more adipose tissue, and I am carrying a lot more adipose tissue than is healthy, and this person, genetically, their body is designed to carry very little muscle mass and very little adipose tissue, but they ended up, for whatever reason, their body allowed them to gain a lot of adipose tissue, and we're both on the same med. Well, the response and where we end up is going to be different. And
Mhm.
and that kind of gets back to, a lot of times when I talk to especially the adolescent females, that identify as female, they have this idea of, like, I want to look like this girl, and it'll be someone who is genetically very, very small boned, depending on the language you like to use, and probably uh, is just a naturally lean person. And then this individual has a lot of muscle, just a strong structure, and that's an incredible body type. And possibly, I love telling adolescent girls and doing a whole evaluation. I'm like, you are incredibly healthy. You don't need to lose any weight. You just have a different body than what you think you're supposed to have. And so I think sometimes that can be a challenge too, because what's our expectation on that other side?
So I have a related question about how social media plays into all this. I met you at the Obesity Action Coalition, right? And the first session, those of us that were content creators were in the room and were like, oh, is this play about us? Because there was a lot of sort of bias against social media and misinformation that was out there. You have so many great content creators in the room right now. How do you suggest that we create really good, helpful content that moves everybody forward?
Mm, that's a wonderful. I think the challenge can always be, as we see in so many areas in our world today, the negative and the bad always it seems to travel faster, it spreads further, and so the good and the well thought out, the intentional, the quality content has, almost has to be more frequent, louder, and that's intense. That's a lot to demand on someone. Um, and the what drives the messaging on each side is hard to figure out. You know, anger and fear is is such a strong motivator, and and we just have to use love and compassion as the motivator that it is to just continue to fight that and continue to have spaces like this to share and bring the positivity forward to try to compete and drown out that noise. Because I have to be honest, I didn't know that you all existed, and wow, it's been wonderful. Like it's just been such an eye-opening, joyful experience for me to see this community. What an incredible community you all have formed. And I have regrets because, man, if I would have known about y'all, I would every single one of my patients would be like, here, these are your new friends. Um, and I feel like I've done my patients a disservice by not knowing. And how to get that out there is a challenge. But I think I have to say, I think it did start that way. But I think you all changed a lot of hearts and minds at the Obesity Action Coalition conference. I think you all did. I think we're convinced to, or they are convinced to engage you all more and to help get the message out and to share the information. And I think a lot of people saw the value in, okay, there are people out there spreading the good information. And I mean, maybe y'all can come to like OMA conferences and
Well,
because
I have kind of
incorporating the
a
patient experience is so important,
I
right?
I was at OMA accidentally. Did I tell you this?
I think you did, and some people walked
Yeah.
out, or
I was at a mini conference. Yeah, yeah. That was built in. It was really weird. But anyways, but I'll be at Obesity Week, so I might see you there.
that's right.
Um,
Yeah.
Let me just say that there is a balance to the patient experience, though, because this class of medication is growing so quickly. There is a balance of experiences that you do find
Mhm.
because you will find places like this space with us, but then you'll also find a series of people that will be like, picked up my first box of Zepbound today, and I can't wait to walk you through my experience. And then 2 weeks later, they're like, haven't had a meal in 7 days, feeling great. And you're like, oh, please eat.
Right.
So like there's a balance of experiences where you're like,
Hmm.
because this class medication is growing so
Hmm.
fast.
Right.
And so you're like,
We're the good
be
cops, but
careful.
what's
Yeah.
happened and why I asked that question earlier is there's so many. people who are getting handed their box by primary care without good information. I mean, I didn't hear anything about protein or movement or any of that when I got my medication. And so I feel like some of us feel like we're the the welcome committee be like, come here, come here. We'll give you the information you're not
Yeah.
getting. So which is
And
why it's
it's
so great
so
for you to
important because treating this condition is not just making the weight go down. Like that is a part of all kinds of different layers. And that's always that's hard because at my practice, our first appointment with a patient is an hour. And so it's an hour, and beforehand, you fill out a weight health history questionnaire of your life experience with eating, and we spend an hour with you. And then we have our health and wellness coach that usually does some type of virtual connection with you weekly. Um, and then if you're open to meeting one of our registered dietitians, who are all trained to talk to people about their relationship with food and figure out where their goals are and meet them where they are, not to be like, here's your plan. And then we see them monthly and their half-hour appointments. And so we take that time to give the whole treatment plan. And some of those appointments, follow-ups, like if someone comes in and, their relationship ended, all we talk about is like, okay, how are we going to get through this time in your life? Let's talk about the skills. Let's talk about the psychosocial. What does support look like for you? Do you cope with food? How can we cope otherwise? How are you dealing with all of those feelings? Because a lot of people don't realize, you all probably do because you've experienced it, but um, if someone has used food to cope, whether they're aware of it or not, and your appetite is suppressed because of the medications, you end up with all these feelings that you don't know how to deal with because you've never had to sit with them and you can't eat the food that you've used to numb. So, who's helping you learn these new skills? And that's just such a significant part of this psychosocial that's so important. And that's the part that drives me crazy and concerned about that other side of social media where people are like, started the pen, only eating celery. And I'm like, oh no. Because uh these medicines aren't medication assisted anorexia. That's not what this is supposed to be. And you're not healthier if you're using a medication to help yourself starve yourself. That's not what this is about. But that's what they're advertising. And the promises that people can come off these meds um, drives me crazy. Because some people may be able to, but informed consent is a thing. Telling a patient, if you start this medicine, you may have to stay on it lifelong to maintain the results. Are you okay with that? Because it breaks my heart when patients have come to me from somewhere else and they're like, "All right, I hit my goal, ready to stop now." And I'm like, "Oh, no, that may not be a good idea." And there sometimes people are like, "I would have never started this if I would have known." And patients have a right to know what to expect if they stop a treatment plan, just like they have a right to know what to expect when they start one. And to just hand a patient a med for a jump start or some of these things that we have no evidence to support is really irresponsible.
Because most patients have not made the connection yet that they're dealing with a chronic illness. And most patients have still in their mind that they're dealing with a lifestyle issue and they're deeply rooted in diet culture. And no one has made the connection for them that this is not a lifestyle issue that you're dealing with.
Mhm.
And if that connection isn't made for them, they're thinking, oh, I'm dealing with a quick fix here. And you have to make the connection for them. You have to help them
Mhm.
see, hey, we're dealing with a long term solution here and this is a long-term solution for a problem
Hmm.
that you did not have a quick fix for. And this isn't a quick solution. You didn't quickly gain the weight. This is not a quick solution for the problem that you
Hmm.
are dealing with.
I don't think I would have started. Remember, my doctor didn't give me any of this information. It was all my fault, right?
Hmm.
I don't think I would have started if I thought it was a lifelong journey. I started because I thought it wasn't, and it was different than surgery, which was short term, was long term. And so it's funny you say that because it wasn't very long in. It was maybe like a month in where I was like, if I can feel like this the rest of my life, if the inflammation in my body's gone down without even
Mm.
losing weight, if I don't have this food noise, why would I ever want to go back?
I know. It's
But I,
so true.
but I know since no one had beaten into my head that it was a disease, it was a moral
Yeah.
failing.
Mm. One one part of I that really, when we realize it, it's one thing, but when other people realize the difference and are changed by our experience, it's incredible too. I mean, it reminds me, my husband is incredibly supportive. I don't want it to come off that he's not. But he's a prior Marine, and doesn't have the disease of obesity. And um, he has always been kind and supportive with me and has thought I was an incredibly valuable person at every size. Um, but early on, when I would use medications or try to have treatment for for my obesity, he always was not bought in. He had doubts like, do you really need a medicine? You could probably, I mean, you could do this a little better. There's this, and it was a place of love and not understanding, right? And I was on different medicines over time, phentermine and topiramate and Contrave, and they all had different levels of effectiveness, but never quite like with Zepbound. And I knew the difference right away. I could tell. But what's been amazing is how much he can tell. Like being on me since my time on Zepbound, he can tell, and he's opened up and shared of like the way you act about food is so like he's a believer. Now seeing me, like he's like, no, 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 because even to the point, we have had coverage recently because of TRICARE with him being in the military, and that coverage ends at the end of the month because they're withdrawing, they're taking back coverage. And I thought I was just going to have to sit down and have a very tough discussion with him and convince him, like, I really need us to budget to buy this medicine, because I don't want to live without it. And I went to sit down. I was like, honey, I got a notice. They're not going to cover the Zepbound bound anymore. And he's like, well, buy it. It's fine. You need it. He's like, this is whatever it takes. You need this medicine. And it was just such a moment of like, wow, I changed the way you feel about it. And he'll talk about how he's like, remember when you went to Europe with my sister and like you were so hungry and nobody else was hungry and you were like losing your mind because nobody else was as hungry as you. And he's like, you don't do that anymore. He's like, you're you're when you get hungry, you're just hungry like the rest of us. And he's like, I'm sorry, I didn't understand, you know, and he's like, and when I used to wonder, like, how is she not full? And he's like, and you're full. And he's like, and I get it. Since you've been on this medicine, like I get it. This wasn't you needing to try harder. There's something that has been corrected. And wow, we're we're keeping this for you. And I love that so much because we just with him as a leader in the military, it's changed the way. he feels about that with his soldiers, with the people he works with when they have to meet these weight parameters. And it's such a beautiful thing to see how these people around us, their beliefs can be changed by watching how our experience with food is different in ways that we probably weren't even aware of.
I have a very parallel story that when I started, my husband, who, is a physician, was skeptical, but I had type 2, so I was going on it for that. And he was actually more than what I weigh now. And he went on a journey and he was losing, but he was watching what I was doing. And he eventually decided maybe he would try out compound. And then after being on this now for 7 months, as I said earlier, he's studying obesity medicine, right? It's gone from skeptic to being along on the maybe I'll try it to trying it to how do I help people get access?
Mhm.
We change lives just by being open. I say that all the time here, right? If we those of us that are willing to deal with the stigma that society keeps placing on people with obesity and with these medications or with bariatric surgery or anything like that, the more we talk about this, the more it changes hearts and minds. It reminds me, frankly, a lot of the experiences being a queer man growing up in the 80s and 90s. Like, the more we talk about it, the more it opens up people's hearts and minds.
Mhm. Yeah. My dream is, I think about people that used to think mental illness wasn't real. People should just cheer up, right? And now, thankfully, we are at a point where it's like, hey, that this is a neurobiological, these are neurobiological diseases. And even like alcohol use disorder, they just need to stop drinking. It's on them, right? Well, now we that's a disease, and yes, there are still some people that don't buy into that, but like for the most part, society has changed the way they feel about those conditions. And my hope is that we will get to a point where we look back and we're like, can you believe that, that we actually thought obesity was something they just needed to like eat less and just walk a little more? That's my hope. I know.
I know we've kept you close to an hour and a half. I don't know how much time you have, so I don't want to steal you too long. Um, do you want to hang out for a little while longer,
I
or
can. I can. Yeah.
okay?
Or unless you guys gotta go. Or,
I'm good. Jay, do you have night plans tonight?
No, I'm not. No. It's Friday night. You know what we
It's
do on
Friday
Friday
night. Why
nights,
would we have
right?
plans? We hang out on
yeah.
TikTok on Friday nights.
Yeah. And I saw a comment earlier, and I just want to share, to be vulnerable. And I have to say, I did some posts on TikTok maybe a year or two ago, and I stopped because I had this sense of who wants to hear what I have to say? And isn't that funny? And so I recently just started again, just in the last few weeks, and I saw someone put in a comment like, "Has Dr. Golden written a book? If she hasn't, she needs to." And I just want to thank. It's incredible to hear that my experience helps so many, and to be vulnerable and maybe commit to this, because maybe this community will hold me accountable. Because Dr. Robin Pashby is probably and my husband are the only people that know about this, and I have started to write a book. About my lived experience with obesity and tying in the science and explaining my stories of what I've experienced to try to bring together the book. It's called Snacks Make Me Angry. And that comes from a line, an experience that I had. um my Trevor had deployed to Afghanistan. And I went, everyone was trying to distract me. And for my birthday, I went to a medical conference in Hawaii, and my sister-in-laws, my husband's sisters, tagged along. Wonderful experience. And we went on the road to Hana. It was like you drive or as yeah. Um, and it was a highly emotional time. We did it. I didn't know two of his sisters very well. We hadn't been married very long. Um, we had got up in the morning and I was trying to play along. Everybody's like, "Oh, we don't need to get breakfast. We'll just like get snacks along the way." Well, that was probably the first problem. And and so it's like this entire day of driving and stress and not knowing where it was beautiful. Like it was gorgeous. And I could not get over the fact that like I was hungry
Mhm.
and there were no restaurants, and the people I was with, none of them lived with obesity or appetite dysregulation. And they're like, here are little peanuts and different things like this. And um, finally, by like 2 o'clock, after like half a banana and sharing some peanuts and like again, one of the most beautiful places in the world, I just finally like was like, no, snacks make me angry. It just this, I was so voraciously hungry and it just it hung there. Like I was just everybody was quiet. They're like, what is she? And for years afterwards, his sisters lovingly would be like, oh, we better feed Leslie. Snacks make her angry. And it became this thing, this little play jab. At the time, I didn't understand the emotional experience of hunger and why I could or couldn't handle it and all this. And I've learned all of that. And um, so I have committed to, and I need to finish it to get it out there. So I just saw that earlier and I wanted to share because maybe this community will kind of help hold me accountable to that, to get this out there of these are the experiences that we have and putting the science to that so that we all can be seen in a way because that's what saved me the most learning about obesity medicine is being able to make sense out of my experiences. And each step of the way, every page I turned, and going back to those experiences and realizing like there wasn't something wrong with me, not in the way that I thought.
Mhm.
It was just my mind and my hormones. So,
Thank you for sharing that. And I guarantee you there's an army of people in the comments who will keep you accountable on that. And you mentioned someone else, and I just want to shout out Dr. Robin Pashby has a book that she's part of that has just came out, and I'm dying to buy it. She's someone
mhm,
I would love to see over here as well, with sharing, because her mindset stuff
she's
is
incredible.
just
Mhm.
tremendous, tremendous. Yeah,
Yeah.
I would the OAC conference for those of you that are thinking about going next year to Orlando or maybe doing the Disney meetup or the day before, which I think we're putting together. Um, I can't say how powerful that conference was and how strong the community is there. It was life changing in some ways. In fact, I just got asked onto an OAC committee, so I'll be doing some work with them going forward. So
Thanks.
highly recommend OAC, folks, if you don't know, if you haven't done it. And if you have any questions, ask me about it later. I would be happy to talk to you.
Isn't it amazing that you have those experiences like that where you felt so alone in those moments because you're like, is no one else experiencing this? And then you have this experience where you felt so alone. You're like, I can't tell anybody else about this moment. I have to take it to the grave because you're like, no one will ever understand this.
Right.
Mhm.
And
And
you're like, how do I explain this to anyone? And you're like, and there's just the shame just runs so deeply, and
mhm.
you chalk it up to a moral failing. You're like, how do I ever explain this to anyone is because of my size, right?
Mhm.
Like, because I have failed somehow, because my body is broken, and the shame just runs deep, and you feel guilt and loneliness and all these things for years.
Hmm.
And
Yeah.
what's insanity about it is that we all know the statistics, right? We know how many people deal with the disease of obesity, and we're like, I can't be the only one, yet you feel like the only one.
Mm, it's
Because
so true.
because even in your own eye, you are always the largest person in the room. Always, right? Your body, we internalize it so much that we hate ourselves more than we hate others, if that makes any sense.
Yeah, they at the OAC, they it was the piece on weight bias and stigma they did where the presenter commented that weight and obesity stigma is one of the only experiences where the group that experiences the discrimination and stigma also prefers the other the other group. Like they just like when given an option, they are trying to be in that other group. And they compared it like ageism. Most individuals who are older that may receive discrimination, they don't want to be younger. They identify with and find the value in being their group. um, Women that may receive discrimination, they don't want to not be women. But individuals who have obesity and experience weight bias and stigma, when asked, they would prefer to not be in that group. And it's one of the few groups in that scenario that makes dealing with the weight bias and stigma that much more difficult to handle because you yourself believe that your group is not the ideal group.
So
If
you
that makes sense.
perpetuate the stigma and the bias.
Right.
Deep, deep.
Yeah.
That's awfully insidious. Awfully insidious.
It's
Mm.
one of the lasting things about the OAC was they handed us all these really, great blue T-shirts, right, that say Obesity Action Coalition right across the chest. And I remember being fine wearing it at the conference, but I remember really freaking out at the idea of wearing it to the airport. Um, and the word obesity being so publicly associated with me, even coming out of that space. And I actually challenged myself to fly with that because when you fly with obesity, it is such a traumatizing experience. And I was like, can I accept the fact that I walk onto a plane with that word blazoned on my chest now that the seatbelt, works? Like, can I do that? And I did, and it was freeing to do it, right? It's hard, but we have to challenge ourselves.
Yeah, I could see that. When I first picked a name for my practice, with my name being Golden, and I weight in gold because I wanted it to be like worth your weight in gold. Like no matter what your worth has nothing to your worth is always still high. It's there, and that was kind of my idea. Um, and now that it's come to a certain point, some of my patients, because we have like little branding and things that we wear, right? And patients can buy it, and so many of our patients are like, I don't know if I can walk around with the word weight on my body. And it's interesting because I'm like, wow, I didn't think about that at the time of can we be confident enough to have the word weight on our body? And so that reminded me of that. What a challenge it is.
Like I've worn coated shirts, right? Like I wear the on the pen t-shirt. I will wear like Fridays, one of the telehealth shirts, like, and people in the know, but the
Mhm.
rest of the world knows what that other word means, and it's hard.
Yeah.
Yeah.
Mm.
Jay, you're thinking.
Mm-hmm.
Yeah. I don't think I've ever worn anything that just. Well, I'm still in a larger body,
Hmm.
so
So am I, dude. So am I.
I don't know if I have to bring extra attention to it.
I know Ted Kyle has a shirt that says "Science, not stigma."
Mm.
That I've seen him wear a couple times, and I want to try to get a hold of that one somewhere.
So, Ted Kyle, folks, is someone who I think doesn't enter this space. Like people don't know who Ted Kyle is. If do people know who he is? Is it Conscient Health?
Mm-hmm.
That's
Conscious
his.
health. Mm-hmm.
That's his website. The information on that, it's sort of like I would call it the New York Times of obesity news. Um,
Okay.
and he is one of the kindest, smartest people you could ever meet. I can't recommend finding ways to follow him. I follow him on LinkedIn, but there's other ways to follow him. He is, when I tell you the New York Times of obesity med of news, for
Mm-hmm.
real.
I saw the other day he was at like an obesity conference in Australia and New Zealand. I was like, how do I get to go to that conference? That's the one I need to go to. Ted
And
Kyle gets to go to all of them.
and he was only because I was sitting with him at breakfast one morning, which is wild that he would just be like, "Come sit with me," but he did. He's like, oh, was only there for like 72 hours. Can you imagine flying to Australia for 72 hours? No offense, James. I want to go to Australia. James is in Australia right now. He lives
Oh,
there, but I'm like, not for 3 days. My body can't take that.
yeah. Oh,
Are there questions in the chat that we haven't hit upon? If people have them, sort of throw them out. Yeah, well, I will make it a couple weeks if I ever come over. For the first time, I will say I feel comfortable enough in my body that I could consider flying that far. Um, and maybe that'll be a non-scale victory.
You haven't made that flight yet.
No, no. My husband really wants to do the Maldives, and for years and years and years, I've said no because I don't want to. I don't want to first go on all those flights, and second, the last little plane is one of the ones where they like weigh you next to the person to make sure they like even out the plane, and I'm like, no, I know it's your dream, but no. And now I'm like, maybe we'll get there. So, what is your top advice for people starting out, Dr. Golden?
mm. I mean, usually the first thing I ask patients to do is forgive themselves. The first appointment, most patients after we go through their history, and because there's usually so much blame that they're sharing, and it breaks my heart too because I see it because they sometimes I have to stop patients too because they'll start to tell me their history in a way of trying to convince me that they've earned treatment, and I often have to be like, can I interrupt? I just need to let you know I believe you. I You don't have to convince me that you've done enough. Like I believe that you've worked extremely hard, and you can just see them like relax because there is this like, okay, let me tell you, I did this and I've done this and I promise I've really done it. And I always want to, oh, I don't want you to sit here for half an hour with that much stress and tension, and I believe you. And and let me take a minute to explain you why you've experienced what you've experienced. And first, I need you to forgive yourself so we can move forward and stop blaming yourself. And so that's usually the first one. And then and the next one is usually give yourself permission to unlearn all of the things that we've learned that aren't going to serve us. Because it's hard for us to go through this journey with all of those food rules in our heads. Like we'll try to help people work through making the medication work well for them, but then they've got the like, oh, but I can't eat past 7. I have to eat breakfast. But if I eat breakfast, it should be this, oh, 5 small meals a day, or is it three regular meals, or am I supposed to intermittent fast, or am I supposed to, and I please give yourself permission to learn a new way and know it is you're not supposed to be perfect when you walk out of here. And when the patients leave my office and they start, I'm like, tomorrow, Friday, you will overeat, however you define that. You will eat something off your plan. You will miss going to the gym, and that's okay. Like, I need you to understand that because this all or none thinking approach is not going to help us. We're learning, and so usually that's some of my first pieces of advice. A lot of times when people leave my office, it's just for that first visit. It's really trying to have give them clarity. And sometimes it's like, this is the only one thing you're going to focus on. And they're like, no, but I need a diet plan and I need to know what my gym workout is. And I need to know this. And I need to know how much water I'm supposed to have. And it's like, I know we're used to that, but that hasn't worked for us in the past. And it may make us feel comfortable to have all these rules, but I need you to lean into not knowing what to do about all this, and I need you to only focus on this one thing, just this one thing. And it helps just give that clarity and also know we're just going to build on that over time.
Can I ask? This is probably the most common question that comes up, that always makes me nervous because we're not medical providers. But
Mhm.
what happens? What's your best advice to someone when they've either, well, first stalled, but then when is the right time to talk to your physician about, or your medical provider about, layering something else in? Because there's a lot of people in the chat who've either hit a stall or hit a mark where they just have stopped, right? They've
Yeah.
lost a
Yeah.
hundred and they're not going further.
Hmm. Yeah. Um, so plateaus are challenging, but they're a success at the same time. Like I always try to reframe that of when you've hit a plateau, all that really has happened, as we lose adipose tissue, the brain learns that, right? As you lose adipose tissue, those hormones being released from that adipose tissue, they fall.
Mhm.
And your brain notices that threshold and it sends a cascade of signals down to try to fight back against that. And essentially, it keeps going, and the brain's sending more and fighting more. And all a plateau is you've gotten to that point where the fight back has balanced the fight forward, right? And it takes, there's a few things that can happen because truly a clinical plateau is you're doing your changes that you're focusing on, I'd say 80% of the time, right? And over 3 to 6 months, we're not seeing progress because a clinical plateau is really kind of your body's time period to decide, like, are we good here? Are we safe here? And is it going to keep fighting back or is it going to allow that to move forward? So anytime if patients aren't having progress forward and you're on a medication and it's 1 to 2 months, I still think it's still appropriate to come in and see your clinician and go over, okay, what's how's our eating relationship? How's the nutrition? How's your movement? Has anything changed? How are you sleeping? Quantity and quality. And then I look at all that stuff, where's your stress at? Because sometimes people are like, oh yeah, the kids are having trouble in school and this happened and their stress is completely out of control. Well, I would not expect it is unfair to expect your body to be able to lose weight in that stage. Um, and then if all of those things look like they're on point, then we need to do a medical intervention. You may need a change in medicine. You may need an additional medicine, a change in dose. We may need to evaluate things like some patients, they have sleep apnea, but they don't want to treat it because they want their weight to reduce enough to where they don't need a CPAP machine. I get it. But if that's not treated and your body's not wanting to lose more weight, you may need that treated to get further weight reduction. So there's so many different things to look at, and it really is that full spectrum. And usually we can find something where we've kind of quiet quitted doing something that works. Some of us, like for me, I'll go and look and I'm like, oh, my protein actually isn't where it used to be. But if everything is lined up, then we may need a medication adjustment or we need to treat a different pathway. Because when you end up in a smaller body, well, you end up in a smaller body, and that smaller body uses less energy. And unfortunately, it can be more and more challenging to keep achieving that progress. It doesn't mean impossible, but we do have to tweak something in those pillars to keep moving forward. Does that make sense?
Oh, you have the entire audience enraptured right now. So thank you. Jay, do you want to
Sure.
talk to that at all?
I don't want to talk to the devil. I look. I had. Hmm, I'm very familiar. I had a stall-ish. I, I had a healthy stall, but I got things moving.
Yeah. And sometimes it's a little bit about throughout the course of things, what we're ready to change and take that next step varies. I know I heard someone share, that reducing alcohol, they were at a point where they were ready to reduce alcohol and it got them out of a plateau. And not saying people have to do that, but it's amazing as we start to feel better and as we move forward and we're at a different phase of our journey, we may be willing to make different choices at that time that could benefit us. But I believe in shared
I
decision making, and for me, I don't like to tell a patient, well, it looks like you could do better on your nutrition plan, so you must do that before we look at other things like medicine or things. No, I mean, it's shared decision making. These are our options where it seems like we could make changes. What do you feel like you're ready for right now? Because this is your journey.
So for me, what ended up happening was during about a year span, I added about 10 pounds of muscle and I increased my movement and then added some Topamax to it. And then things started moving back down. And then we're good. So nothing crazy. Yeah. So yeah.
Yeah. And these things, it's all based on what's best for you and working with your provider, right?
Yeah. Yeah.
Um, and hopefully you have a provider that listens and knows the field to know the different options. Because some
Mhm.
providers aren't comfortable with using multiple medications to manage, but a lot of us who are very experienced in the field, we are. Um, just like I said earlier, I mean, sometimes depression and anxiety needs three or four different medicines to stabilize.
Mhm.
When people have diabetes, they can be on multiple medicines, and it's another part of that weight bias and stigma if people feel like, oh, you can't control your condition on one medicine. Well, sorry. No, we have tools. We should use the tools.
I eventually brought in an obesity med doctor as a coach and a cardiologist who's deeply works in the obesity field. And the thing that I think helped me about 6 months in was them actually saying to me, look, like this is where you're likely to end up. It's not going to be where you think you're going to end up. The meds are only GLP-1s only can take you so far. So just be prepared for the possibility of layering something in, whether that's surgery or whether that's another medication. And it was just so helpful to set my expectations differently. That and doing, in my case, a DEXA scan and understanding when the clinician said to me, well, I mean, if you were going to be in a healthy spot, your weight's actually like 210 based on how much muscle you have in bone mass. And I was like, oh, it's not 180. Like I've always been told it was 180. I'm so confused.
Oh my
Mm-hmm.
God.
And resetting
DEXA scan
expectations.
changed my life on this journey.
Mm-hmm.
Like
They're
I
incredible.
I set a goal weight for myself at the beginning of this journey because I wanted to be a normal BMI because that's what you want to do. You want to be a normal BMI. I would have had to be about 5% body fat to be a normal BMI.
Uh, I will tell you, Jay, I really liked the Sika scan I had at OAC. I bet you'd like the data in that a lot.
Yeah.
I'm I'm yeah, I use Sika at my clinic, so of course I love them. It gives incredible data, and sometimes we'll send patients for DEXA scans too. And I being wanting to make sure the care I deliver is high quality, I will at least once a year I'll get on our Sika scan at my office myself, and then I'll go and get a DEXA scan that same day to make sure. And wow, it's amazing how accurate it is. But yeah, the Sika, in like a minute and a half in the office, it is able to quickly give you a printout of how much of visceral adipose tissue you have. So our adipose tissue, fat tissue, is in two different compartments in the body under the skin, which is the stuff that we're like, this needs to go away. But then the other part, it will get in the tissues, like in our, excuse me, in our organs, like liver, kidneys, heart, places we don't want it. So it can tell us not just what our body fat percentage is, but how much is actually in the organs. And that's and being able to track that in addition to seeing your skeletal muscle. And but it's so much value because that's the disease, right? If I don't have any adipose, well, if I have very little adipose tissue in in my organs, because it's hard to have zero, but and then I have a healthy body fat percentage for me, or I've been able to really reduce my body fat percentage. Who cares how much I weigh? Who cares how much space I take up? It's healthy tissue, and that's what's so valuable with those scans. And you're completely right. BMI was never meant to be a goal. It was never meant to be a goal for people to achieve, and it was never meant to be accurate for every single individual. Because you're right. I mean, I've had patients where it's like, if you were at this weight, you'd have extremely low, unhealthy amounts of adipose tissue because adipose tissue is a vital organ. We need it. It is not supposed, this war on fat tissue doesn't make sense because it is a vital organ that we actually need. It releases hormones that are necessary for our body to function. And so many people forget that. And you know, it's fun to teach that to teenagers because they think fat is just something that is all wrong in our body. So to teach them, like, just like your liver or your heart or your lungs can develop an unhealthy state, so can your adipose tissue. This is just an organ. And it really helps us to become neutral about this organ. But I'm seeing people make comments about insurance and measuring the body comps, and some insurance companies do cover them. But yeah, we are definitely fighting for that because it's like measuring high blood pressure without a blood pressure cuff. Like, how do you know?
So we have 50 people in the room right now. So this seems like a good opportunity to just talk about how they can advocate for the kinds of things for obesity care. How do you recommend doing that, Dr. Golden? Because I'm
Mm,
like a broken record on here. So
yeah. So, Treat and Reduce Obesity Act. I mean that the Treat and Reduce Obesity Act is a piece of legislation that has been introduced multiple times to Congress, there's a bill out there now. And this bill, if passed, would uh, allow Medicare to cover obesity medications. And currently, Medicare cannot because of just an old prohibition written against weight loss drugs. In a time that we didn't understand the science. So, the Treat and Reduce Obesity Act would allow Medicare to cover obesity medications. And then there's a part in it too that would expand coverage of intensive behavioral therapy, which are the frequent visits that we try to offer to our patients at Weight and Gold, where they meet with our health and wellness coaches and get that those skills, that support, that accountability that we all need so much to be as successful as possible and get well-rounded care. And I know a lot of people are thinking, I'm not on Medicare, that doesn't help me. But most insurances follow what Medicare does. So if Medicare covers the medications, then most of we anticipate that the commercial insurances will then have to follow. So that is a big way of trying to get this expand access is to get TROA passed. So you can reach out to your representative, your senator, let them know how important treating obesity is and the experience of living a life with obesity and potentially the experience of living a life with treatment so that others can get access as well too.
And it's so easy, folks. You literally just go in Google, type in Obesity Action Coalition, OAC, Action Center. You'll see right there in TROA, there's a way to just enter your zip code and it'll pre-fill out letters for you. I found one for Massachusetts because the public health insurance here for the public employees is taking away GLP-1s, which I'm actually on. And so I was able to write my governor, my state legislator, my state senator, and you can do the same thing for TROA. You can get both of your senators and your representative easily done, and you can either send in a form letter or you can adjust it like I did. It took an
Mhm.
extra 10 minutes and you just hit
Yeah.
send and it's off.
Mhm. Yeah. I personally think we need to organize a march. Just saying. Well, just because, if a disease like cancer wasn't covered, like people would be marching in the street. And I personally believe that it is another one of those things where they're taking advantage of our internalized weight bias and stigma. It is
Mhm.
hard to get on the phone or get on out on the street, just like we were talking about not wanting to have obesity on our shirts or weight on our shirts, to go out into the street, to go to your governor's office and be like, I should get care for my medical condition. If this was cancer, people would be in the streets marching. There would be uproar. But because it's a stigmatized condition, there hasn't been that level of organized movement and intensity. What do you what do you
I
think? How does that sit with you?
I agree. There was someone on here trying to form a march on Washington right around the time of Obesity Week. She's now going to Obesity Week. I should introduce you, but she's thinking exactly along the lines that you are. Um, she's trying to raise money to make sure people who can actually afford to go. That was sort of where her fallback was. But instead, she's going to take her efforts to Obesity Week. So we'll see what happens.
I know we're at a very exciting time for the treatment of obesity and for the future of obesity care. But I'm curious, Dr. Golden, for our efforts, who should we be concerned about falling through the cracks for this care during this exciting time? Who should we be looking out for?
Hmm. I mean, there's so many layers to that, right? Because you could look at it as, our children living with obesity. where there's a lot of misinformation and misunderstanding about the disease that children can just, they'll grow out of their weight. If the parents just fed them better, this wouldn't be a problem. Maybe if you sign them up for basketball, this would
Mm,
all be better. And I get challenging phone calls, is the best way I can say it, from pediatricians that don't like that I use medications on adolescents, that have obesity, that already have changes in their liver, that already have prediabetes, because they don't agree. Um, so one group that I have concerns about are simply our children that the one continuing to have obesity throughout childhood makes it you higher risk to struggle with not having obesity as an adult. Even if you are able to weight reduce, your risk of weight recurrence is just so much higher. So I worry about that population no matter what, because the level of childhood obesity is growing and growing in our country. And even
mm,
if we get coverage and even if we get advances of care, this judgment and attitude and concern, for not trusting the science, uh, continues to put generations of children at risk for just delaying their care until adulthood when they can actually stand up for themselves and make their own decisions. Then we look at populations, that are at the highest risk because of their social determinants of health, because of
mm,
their economic situations, because of they can't purchase these medicines for themselves. Or I have patients that are, and they're maxing out credit cards to do it, but that's not sustainable. Our individuals that live life with disabilities that are at higher risk for obesity already, and who's advocating for them, and getting them on medication. And so there's so many groups that I think about, um, that I have concerns for as access improves, as options or improves, and as options improve, we still have populations of individuals that it's not just getting access, it's maintaining access, it's having access to refrigerators to keep the medication consistently, in an active state, and also to have access to the quality of food that doesn't make the disease progress. We know that foods that are highly processed continue to cause inflammation in the hypothalamus. So if I have access to the medicines, but I still don't have access to quality foods, and a lot of my nutrition is coming from the food pantry, my disease is just going to keep getting worse despite medicine. you
mm,
know, and 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 kind of like someone who you may be treating lung cancer, but if they're still exposed to terrible air quality, well, they're still exposed to those toxins. So so it's a challenge in multiple populations that I have concerns for.
that's a lot to consider, for sure.
What makes you the most hopeful right now with where we're going with obesity?
Seeing individuals like Serena Williams just come forward, an elite athlete, um, you know, in just at talking about someone that puts forth all the effort, and still has biology that needs to be stabilized, corrected, and seeing people like that come forward and speak and share, that gives me so much hope. Um, because people see that and they give themselves permission. Individuals who maybe have not given themselves permission to seek treatment might see themselves in that and can trust that. I hate that it would take that to legitimize the experience, but for some people that have judged it, that may legitimize the experience. So seeing things like that bring me hope. Um, Seeing individuals talk about the treatment as a spectrum and options and not just or, um, brings me hope. Seeing metabolic and bariatric surgeons and obesity medicine physicians work together more and come together and stop fighting each other and realize we have to come together and fight this together. It's not you can help them or I can help them in a turf war. This is a disease that will take all of us. That brings me a lot of hope. And communities like this bring me so much hope, to see that, because we talked about the psychosocial, and I imagine at some point in my life I will retire, you know, and and people will continue to need support, and I'm training others. I have a team. I have six clinicians that work with me, and I'm trying to train them in my approach, and I hope they will pass that on. But it brings me so much hope to know that there are communities like this, that even in areas of the country and across the world, Australia, we're going to come visit you. Um, that that they can find that, and they're not alone, and this community can help them find the clinicians that they need.
Thank you. Folks, if you aren't following Dr. Golden and Jay, please, please, please give them follows. We want to encourage both of them to be creating content and getting as many followers as possible, because the more followers they get, the more they can do on these platforms.
Wonderful. Thank you so much for having me on. It's been a joy. Thank you for letting me share. And like we talked about earlier, right? Sharing our stories is so important, and that's the only way that we can get past the shame. And you have created a safe space for me, and I appreciate that, and I am grateful.
Thank you for being here. Oh my gosh, you are an absolute amazing gem of a person, and the work that you do. I know you've heard it before, but you are absolutely changing lives, and being in a space like this, you're touching hearts, and the way that you just speak to us and speak for us and with us, it's making a difference. So just thank you. Really do appreciate it.
Social media is such a force multiplier that you can help so many people with just a few words at one time. It's amazing. I am I mis- Where can what states can patients be in to see you? Is it just Wisconsin?
So, anyone in the state of Wisconsin, I can do virtual care for Illinois. So,
Excellent. Excellent.
Sabrina, your dream came true.
um, well, I just want to thank you again. This is two Friday nights in a row that you've graced us with your presence. Your openness, your authenticity just really resonates with this community. We thank you. It means a lot to us to have you here. So,
mm, thank you. Thank
and,
you
th-
so much.
and thank you to everyone in the chat. Thank you for getting us to 40 plus thousand likes. Thank you for
Wow.
all the gifts and all the love. We can't thank you enough. Have a great night, everybody.